Hello, hello, and good morning, wherever you are. Give me a hi, hello. It is so good to be here with you today talking about adapting myofunctional therapy programs. You'd be surprised to know that not everybody needs to work with you for an entire year. Not everybody has to have 12 sessions of myofunctional therapy. There's a lot that can be done in just minimal programs or abbreviated programs. Hey, Cindy, good morning. Thank you. Oh, Happy New Year to everybody. Thank you, Cindy, for that wonderful reminder. I feel like we'll all be saying Happy New Year for the next, I don't know, however many weeks, but Happy New Year. All right. Now, as I always do, hi, hello, welcome. Glad that you can hear me, you can see me. I'm just going to remind you, we want to keep this going. I'm here, I'm live every single week. You didn't see me last week because of the holidays and I kind of took some time off, but I'm here. We're going back strong. So, all you got to do, just keep this going. It's free content. Just like, comment, share, make sure we get the reach out, okay? Get as many people as possible watching. If you're following me and watching on LinkedIn, connect with me. I love to connect with people. Shoot me a message in my inbox. Happy to chat with you anytime. And if you're watching on YouTube, just hit that subscribe button and turn on notifications so that you never miss any of these lives, all right? So let's jump on right in there. Fun fact. Hey, Roxanne. Fun fact, not everybody needs myofunctional therapy, and certainly not everybody needs a whole program of myofunctional therapy. There are probably people that you may have spoken to, or if you're newer, you may not have gotten there yet, where there are people you will speak to that sound like they have every little thing. And it's like, oh, my gosh, you are not getting good sleep, you have issues when you're eating, you have headaches first thing in the morning, you've got jaw pain. It sounds like you need absolutely myofunctional therapy. Now, if you have watched my previous lecture about consultations, you know that I always start with a consultation. And so you might talk to these people before you ever get to see them, get hands on them, or really get to evaluate them and assess what's actually going on. But you'd be surprised to know sometimes that for all those people that have all of those issues, sometimes they're just not in need of myofunctional therapy. Like, you get in front of them and you're looking at all these things and you're like, I don't know. I don't see the problem. I don't see like a very overt tongue thrust. I really don't see any tongue thrust. They swallow and it looks like it's normal. I don't see any of the asymmetries that I expected to see, or some of the recruitments I expected to see. It looks like everything is relatively fine in some areas where you expected there to be a problem. So you might find a thing or two, or you might find something that you want to work on, but it just doesn't look like it's worth a full program. And I've been there when I was in the beginning of doing myofunctional therapy, where I'm looking at people and I'm like, I don't know, I don't think you need myofunctional therapy, which honestly, if I could go back in time, I would say, look, you don't need a full program, but there's definitely things we could work on. And so let's do something abbreviated. But hindsight's 2020, and that's why I'm here with you today. We're really going to be talking about how you can kind of get over that hump and just understand that we can do a full program or we can do something smaller, but no matter what you do, people are going to feel better. Um, it just is a matter of perspective and understanding and knowing what it is that you do and being confident in it, and really assuring them along the way that this is the dysfunction, this is what we have to work on, and if we work on these things, we're going to get these outcomes, and these outcomes are really the ultimate goal. So it doesn't have to be a full program. So if you're used to something that's cookie cutter, or if your first program was something super cookie cutter where like everybody follows the same sheets of exercises, or everybody does the same things, or visit one always looks like visit one and visit two always looks like visit two, and you don't do it customized, you might struggle with abbreviating a program. But I'm going to give you a little bit of my my program sequencing, and what I used to teach, what I still relatively do teach in sequencing a personal program, so that hopefully by the end of this, you'll be able to create an abbreviated program, or at least understand where you can and cannot make an individual program happen. Okay. And to really like drive this point on home, we're just going to have to get real for a second and understand that most of the research that's out there, and I don't want to put research in quotes, but a lot of it's case studies or like very small sample sizes. And so it's not high quality research. It's still research, but it's not high quality research. A lot of the research that's out there is really based on limited programs with 7 to 10 exercises, and specifically anything that's like oral pharyngeal exercises, which is what a lot of people try to reference back into myofunctional therapy when they talk about myo and reducing AHI and being able to help. They're really talking about like a sequence of exercises or a specific set of exercises. So even if it's not sequential, if it's like these 5 exercises that we had 30 people do for 4 weeks straight, and then we did another sleep study, and that sleep study really showed us that they had improvements in the AHI based on this or that or whatever. So we know abbreviated programs work. I mean, if you're reading the research, if you're really understanding what you're reading, if you're really looking into what oral pharyngeal exercises are, or what some studies call myofunctional therapy, which is really just a set of a specific sequence of exercises and not exactly a personalized provider based program. It's always about an abbreviated system. And that's how you keep controls in research studies. That's honestly the best way to do research when you're doing real legitimate research. You have to have some control. You have to have things that are equal amongst people, even though you're talking about something that can vary so wide amongst different people. Okay. This is even proven to be true with all of these wonderful apps. Like, I don't know if you guys have seen Snore Gym or like some of these apps that are online. I want you to go into your app store and look for snoring exercises and watch how many apps come up and look at how many things there are. Like, there's a lot of things out there. And when you look at the reviews for them, there's so many people that are being helped. It works. Like, abbreviated programs work. This isn't real myofunctional therapy. It's more like oral pharyngeal exercises, like the research has. And then we know that there's all these things. Replenish really bases themselves on the fact that they do like have a myo based program. It's a muscle based program that is really helping while you're drinking from their nozzle. Like, this is the thing, right? Or like the froggy mouth, or we have the myo chew or the myo munchie, and all these things. They have their own sets of independent research studies, cases, and so forth, where it shows that these things work to do some of the things that we do anyway. So you don't need a full program to get to a specific outcome. It just doesn't need to be true in that way. Hopefully, you're not confused about that. Hopefully, you're not looking at that and thinking they took our jobs. I'm terrible at that. That that imitation or whatever, but I think it's really funny because sometimes people do get upset, like, oh, there's all these videos on YouTube or all these, exercises that are out there, or these apps or these things, or like people doing all these gimmicky things. They're not taking your job. To be honest, you can look up anything online. And I always use the roof reference. And I really don't think the roof reference is totally relevant anymore. If we're going to talk about, mimicking things, there's a lot of tools that try to mimic, like a Cabotron out there for all of us hygienists, that is going to like get all the tartar out, and people can buy their own little hygiene stick and clean their teeth themselves, or they can take a certain thing, or they can do oil pulling, and they're going to be able to get all the tartar to go absolutely away. And I mean, I think we all know it's ridiculous. They're not going to get the outcomes that they're looking for. They might do more harm than good, which is what I think we find most often when we're talking about mewing, and how, it had a great intention, but it was very poorly executed. It is something where it's not a replacement for us. It's just something to reinforce for you the importance of working one on one with somebody. It does not take away from you in any way, shape, or form. People get results from a lot of different things, and myo isn't always special. Oral pharyngeal exercises aren't necessarily myo, and myo isn't exactly built around all oral pharyngeal exercises. It's a different dynamic. So you don't have to feel threatened by any of that. Just know and understand that the concept of having a target and having a abbreviated program is something that works. Okay. And it does not replace in any way, shape, or form a full program, but it does help people who need help. And that's our ultimate goal, right? We have these people who are desperately seeking help. They need something to help them feel more capable or in control or more functional, or just to present where they're running on full instead of feeling like they're always working with what is left over. Okay. So we can help people. Here's where you can abbreviate a full myofunctional therapy program. Now, this is not a comprehensive list by any means, but it is a list that I decided to break down for this because I think it's the easiest way to process it. And so we're going to talk about all of these, I promise, in detail. And we actually will come back to this very same slide very, very soon. But here's where you cannot abbreviate. Like you have to have these cases that are absolutely 100% free of improper oral phase swallow. I don't know how everybody else is trying to do their programs, like how they sequence it, especially an individual or personalized program. But as far as I'm concerned, a myofunctional therapy program has to build on itself. And I always say it's like Legos, where phase one is isolated exercises. Yes, it looks like all that stuff you see on YouTube. It might look like mewing. It might look like oral pharyngeal exercises. They're individual exercises that are really trying to target asymmetry, underdeveloped musculature, overdeveloped musculature, and target, strength, awareness, and range of motion. So we're going for individual exercises. That's just phase one. Phase two is what makes it myofunctional therapy. If it's going to be a therapeutic process, it has to have this element of it. So phase two is going to coordinate. So now it's looking more like activities, because now we're going to coordinate what muscle groups are supposed to be functioning. Like, what are you looking for when you're doing such and such task? That way you're able to really bring the pieces together, and cognitively, we're starting to plant the seeds that are going to establish neuromuscular reeducation. So it has to be there. If you don't have that, you've got nothing. And that's not on YouTube. That's not out there in research or in those papers or in oral pharyngeal exercises or in the Snore Gym app. It's not there. This is where you shine, right? But then that last step, phase three, habituation, that's the most important Lego. Consider that the flag on top of your castle. Habituation is when you start integrating it into daily life. That's where you really work on things like improper oral phase swallow being remediated, unilateral mastication being remediated. You're working on those things by integrating it into their daily life. If you're not sequencing your program in a way that it's going to go from exercises to activities to habituation, I don't know what you're doing. I really don't know what you're doing. Don't call it myofunctional therapy. But I like to think that 99.9% of us are doing it in that way. Even if it's cookie cutter, I hope that it is sequencing and leading in a way like that. So you can't get to habituation through a abbreviated program. That's just not how that works. Like, if they have an improper, oral phase swallow, you're going to have to do the full program to get to habituation, to get to that really being remediated. Otherwise, I don't know what you're doing, because you're not going to gain anything. You're not going to get anywhere, at least not fast. That unilateral mastication is the very same thing. Trauma is a very big one. I don't think we talk about it enough as a profession. I talk about it and I kind of touch on it in my myomodalities course. But trauma probably needs to be a live stream that we do. Tell me in the chat if you want that to happen. But it probably needs to be a bigger thing that we talk about. We don't talk about sexual assault enough. A lot of sexual assault sometimes happens in the oral cavity. We talk about sexual trafficking and abuse. And we talk about that in dentistry. For those of you who are in dentistry, in some states, this is required education because this is where you're seeing abuse happen. This is where you're seeing these things happen, sometimes in children. And we're mandatory reporters. Like we note this stuff and we have to report it. And so trauma is a very big thing that is super layered, and sometimes you trigger trauma in the middle of myofunctional therapy. And if they don't tell you that there's trauma, sometimes you're spotting signs of trauma, or you're spotting things, or you're noting that there's certain reactions in certain ways. And listen, The Body Keeps the Score. That's a really good read for anybody who hasn't read it. But trauma is a big thing, that if there's trauma and they're telling you about this trauma, or you're able to see signs of trauma, you're not going to be able to abbreviate a program for them. Don't even try it. You're going to lead yourself way astray. Trauma can also be head and neck accidents, sports accidents, injuries, slips, falls, car accidents, those types of things, where there may have been whiplash and there may be some mismapping in the body. And so they can't coordinate appropriately until that has been corrected. And so you can't do a short program for people who have trauma. Hopefully you're asking about it in some way, shape, or form. It doesn't have to be verbally. Sometimes it could just be on your paperwork, or something that you might notice with your eyes based on just having the proper training for what oral trauma looks like. But it just can't happen. Okay. Congenital disorders always require something more. Like, I never look at a case that comes to me with congenital issues, or where there's any sort of like uh, dysfunction, deformity in structure. I don't look at any of those as, let's figure out a way to make this short and sweet. We can't make it short and sweet. It needs more than what somebody who comes in without a congenital disorder needs. They just do. Sensory issues as well. Sensory issues always require a bit more finesse and a bit more collaboration, is what I'm going to call it, where we're working alongside somebody who's going to work on some of those sensory skills, but definitely manual therapy. So manual therapy, I would always have in a case where there's any sort of sensory disorders or sensory issues. So please, 100% make sure that if you want to abbreviate a program, that you're not looking at people who are presenting with any of these issues. If they are, then you want a full program. Don't try to abbreviate it. I don't care if it's about finances. Like, I don't know how many people I tell this to, like, do as I say, don't do as I do. But I'm one of those people who run business with a bleeding heart, and it's terrible. It's absolutely terrible, guys. I'm going to tell you that. So that's why I say do as I say, not as I do. But I will absolutely discount a program for somebody if I feel like they need it, but they can't afford it. I'll absolutely discount it. My program fee is a one set fee based on results. So I don't care how long we're working together. We can work together for 2-3 years. That's never happened. Just one case where I've worked with somebody for 2 years, but other than that, it's never happened. But we could work together for an extended period of time, and it only costs you this one set price. After that, we're just going to keep going until we hit goals. If we don't hit goals, then we just keep at it, and we will get there. It's just a matter of time. And so don't structure your program like that, but find a way, if you really want to help these people. If it can't be you, direct them to somebody else, or give them some other resources. If it can't be you, don't try to abbreviate a program for anybody in this sort of situation if you can't work with them at your rate for whatever reason. But it's always nice to be a little flexible. Okay. All right. So we talked about who not to abbreviate. let's talk about who you can abbreviate and how you can abbreviate it. Some of these are very obvious, tongue tie and like mini myo, very, very obvious. Some people think TMJ has to be a whole full thing. It really doesn't. There's a lot of ways to approach TMJ. There are people who do all sorts of things, whether it's photobiomodulation or acupuncture, or they see functional specialists, or they get a splint, or they see a myofunctional therapist, or there's so many ways to approach it that it doesn't have to be a full program in order to approach it. That would be what I would think is the absolute best bet. But if they do present without some of those issues that we talked about on the last slide, I don't see why you can't abbreviate TMJ to be just focused on that. OSA, obstructive sleep apnea, breathing, vagal tone. Breathing and vagal tone will kind of squeeze together later, but let's jump into tongue tie, okay? So with tongue tie, there's a lot of work you can do pre-release and things you can do post-release. There are some people who are newer who I've spoken to relatively recently, just before the holidays, where they say like, oh, in my program, they told me we do this specific sequence of exercises. Okay, but what are you accomplishing? I just really need to know, if you are a therapist, you have to understand why you are therapeutically ascribing a certain number of exercises or a certain sequence of exercises to these people. So while I never do a full evaluation, like a full, comprehensive evaluation, I do a little micro evaluation. I want to see where their current range of motion is, where their current mobility is, what skills they possess, what skills they lack, and where I can maximize that, because that's exactly what you're trying to do for a tongue tie pre-release. Let me not skip over that first bullet point. First of all, not everybody who presents with something that looks like a tongue tie has a tongue tie, like point blank, period. Okay. I got a call from somebody like 2 weeks ago who was like, hey, I don't have any problems. Like, I have no issues. My doctor said I have a tongue tie, and so I want to get it released. And they said I have to talk to you first. I was like, so you have no issues? None whatsoever? No, like, my issue is my tongue. It is tied and I need to have this thing done. And I'm like, okay, so you want it done, or like the doctor wants you to have it done? Because at that point, I'm like, if you have no problems, there's no dysfunction, like, why are you doing this thing? It's just very confusing to me. Not everything that presents or looks like a tongue tie is a tongue tie. Okay, so first, determine whether or not they need a release. I think that's the very first thing, and what I'm always talking to people about when I do consultations. Like, this has to be for a specific functional reason. It's not because we see something. We're not doing tongue ties for just cosmetic purposes, although that's all the procedure is. All the actual work is when you're working with a functional specialist. So removing a piece of tissue does not automatically change how all those muscles function, how that wonderful respiratory organ that's your tongue functions, how your lips function, how your cheeks function. Like, it doesn't change that. It just removes a piece of tissue, and then we got to do the work, right? So once we're in there and we know that, okay, they need a release, now what are their capabilities? How is their tongue cupping? How is their lateralization? How's the protrusion? Can they hump their tongue? Do they have access to the back of their tongue? Are they able to elevate? Can they establish a tongue tip? Like, these are things we need to know. You have to be able to maximize on what they have currently and whatever that range of motion might be. So even if it's just establishing like tongue tip awareness, if somebody who's like super, very, very like true ankylglossia tied to the tip can't really do much of anything, even just establishing sensory wise, like, your tongue tip would be here. This is where we're going to elevate. We're going to stimulate. We're going to do this. We're going to do that, just to get that awareness and the proprioception enhanced. That way, post release, once they have more access to that, they actually know now what needs to go where, and they're able to really perceive what it is you are instructing them to do, as opposed to going into that blindly, which is much more difficult. Okay. You need to be able to establish lingual palatal suction where you can. Sometimes, again, with those very, very restricted people, you're not going to be able to get a suction, but most people, you're going to be able to achieve some sort of lingual palatal suction and seal. So that's tongue to the palate connecting and being able to sustain that for a minimum of whatever the duration your provider is working with. So some people are telling me, oh, they have to be able to do it for 3 minutes, or they have to be able to do it for 5, or they have to be able to do it for 90 seconds, or they just need to do it for 60 seconds. Whoever you're working with, there's no standardization in this field. So there's no reason for you to think that, you're doing something wrong if you do it for XYZ amount of time. Maximize to whatever the person you're working with would like you to have it maximized to. And then it doesn't make sense to work with a tongue and not try to establish differentiation in movements between the tongue and the jaw. So your tongue and your mandible shouldn't be carrying your tongue through all these things. And yes, people are going to give me all that floor of mouth and yada, yada, yada. But you can establish lingual mandibular differentiation. You're just going to start to work on it pre-release, and you're really going to get it done post-release. So you can start to work on isolating the tongue in different motions and getting the tongue to be its own independent movement, like, I don't know, whatever, moving organ. You're going to get it to do what it needs to do without depending on the lips or the jaw for that task. Post-release. Active or sutured wound management is absolutely key. I start working on that pre-release, of course, but it just felt better to put it post-release because that's when you're really, really working on it. So you're instructing them and kind of guiding them, like, what is going to happen? What do they have to do? What are certain stretches? What are the protocols? And sort of like really getting that down, but they're not really in it until they're post-release. So post-release, you're working on all of that. You're going to maximize mobility and range of motion. Again, so like everything you did, you're at like a reset. So where you maximized it, now we're getting even more. Okay. So this should be at least 3 points where you're doing measurements. So one is when you first meet them and you want measurements for their maximum opening, tongue to spot, like, and their lingual palatal suction. So you want those 3 measurements first thing, like, hi, hello, how are you? I'm going to measure. And then your next step should be right before release, just to see how much you've maximized. If you've maximized, then, where you can go, like, where are you pre-release, and then immediately post-release. I like to do one again, like, so I'll do a 4th after we've been working together and everything has healed. Like, where are we now? Because there's always naturally a little bit of loss. It's fine. Establish lingual mandibular differentiation, like for real, once you're at that point. Okay. So when you are working with a tongue tie case, understand that you're not going to get to adequate function. Like, they're not there. They're not going to be more functional, but they will definitely have improved range of motion. They will have some lingual mandibular differentiation. They will have like better mobility and likely better measurements, but you're not leaving them in proper oral rest posture. Like, that's why it's an abbreviated program, because you just really focused on them getting the maximum results from a tongue tie release as far as healing and range of motion. Okay. Awesome. Mini Myo. Mini Myo is, I really love this picture of this little girl. She's on my website, and Mini Myo, I think, is really, really fun. Like, I never have more fun than when I'm working with these cases with these smaller children. So Mini Myo is like 3 to 5 roughly. And in that age group, you're going to have some kids, as long as they do not have like real feeding issues and disorders, and the parents are coming to you because they're like, oh, I've noticed this thing with mouth breathing, and I can't have my kid mouth breathing. You're like, okay, well, here's what we can do. We can get into some nasal hygiene. We could start working on you and them with that. We can get into introducing and encouraging chewing through using a Myo Munchie or a Myo Chew. Yeah, I hope nobody there saw that and was like, oh, chewing, that is like a feeding task. No, 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 no. We're doing chewing with like a functional appliance. I guess that's what we can call those, where they're going to put it in their mouth and we're working on getting the lips to close while they have that appliance in and while they're chewing on it. And if you have the Myo Chew versus the Myo Munchie, you've got the little tongue tab. And so you're encouraging them to play with the tongue tab, which will help with the anterior tongue posture. And so you're kind of getting a little bit of the foundations of what they really need when they're older, like a full program. But you're able to start with like a little program, making it super fun, doing exercises, doing exercises, not necessarily activities. I mean, some are activities, but we're not coordinating in the same phase 2 way of a full program. We're just more having fun in a dynamic way, but working on lip seal and lingual muscular strength and awareness. This is all mini Myo, and you can abbreviate a program and work with these children 4 to 6 sessions, something super small, but like it's something that helps. It creates a solid foundation. And that's what we want. We want a good foundation. That way they can build on these skills when they're old enough and ready for a full myofunctional therapy program. And it's something so that the parents don't drive themselves crazy, because a lot of these parents are doing all of these things or trying all of these things or ordering all of these things thinking that this product's going to help or this or that or whatever. And it's like, you don't have to do all of that. We can create a solid foundation, we can do a little bit of something, and then you'll be able to do more when they're a little older and can follow directions appropriately, can really be an active participant of a program. But we can introduce really good habits that start to encourage them in the right direction, so we can kind of shift the trajectory instead of just leaving them alone and saying, oh no, there's nothing I can do with you until you're 5. There's a lot you can do. You can work on some things, okay? Not everybody's going to agree. I hope I don't get a bunch of hate for the mini Myo thing. I love my SLPs. I love my OTs. And there's so much that I refer out for to those other specialists who do great work with feeding and like real issues that some of these children have. When I note that there's not those major feeding issues and it's really just these parents who need something, that's when I'm intervening with like a mini Myo program. So every professional has their role. Just stick to your role, I guess, is what I need to say to be politically correct in this situation. TMJ. TMJ is another one where we can abbreviate a program and we're just going to really focus on what's happening with the joint itself. Again, if there's any structural problems, you cannot work with the TMJ, especially on an abbreviated program. But for like a full program, you're gonna struggle a bit there too. And so that's always collaborative. But if there's no structural issues, it's muscularly involved TMJ issues that they have. There's not breakdown on the joint itself. It's not arthritic. That there's no syndromes or issues or condylar resorption or anything like that. Good to go. You could do a TMJ abbreviated program. You're really educating, a lot of education. There's so many habits, like whether they're doing, I don't even know if you guys can see that, but where they're doing a lot of leaning or they're like sleeping on their hand or they're clenching or they're whatever. You can educate on all these poor habits and really encourage a better lifestyle. Like there's a lot that can be done when you just change your diet, when you stop eating inflammatory diet, if you're just aware of like lymphatic drainage and lymph movement and massage. The lymphatic system is not a circulatory system. Yes, lymph drains into the nodes, but that does not drain out of the nodes to clear the body unless enough pressure has built up. So you need to have the ability to alleviate that pressure. And so it's a pressure-based system. You want to know how they can do that. If there's a lot of great massage or things or the gua sha stones or things that they can do to help remove some of that lymph and some of the inflammation that might be inhibiting them or prohibiting them from accessing their muscles to appropriate better tasks. So encouraging a healthy lifestyle, a lot of water, not anti-inflammatory diet, lymphatic drainage, like all of these things, really, really good. And you can introduce functional movements. Now, there's a good bit of functional movements that I really would prefer they did a full program for, but you could do an abbreviated program and you can establish some functional movements and really eliminate some compensatory function in the muscles of mastication. But you can't do it entirely without getting to phase 3 of that program, which is like the habituation, integration into daily lifestyle. And so ideally, you want a full program, but you can do little bits and things and you can make some progress. The biggest thing that we do in myofunctional therapy, when there is disc displacement, we are able to establish a pseudo disc. So by appropriating functional like movements and functional patterns for the joint, we're able to develop a hardened piece of like tissue that will become a pseudo disc. So it's not their disc, and their disc itself that might be anteriorly displaced will resorb, the body will resorb that, and then the disc, new disc or pseudo disc, is going to now sit and be the buffer between the condyle and that joint space. And so we're establishing that pseudo disc. So you can absolutely do that in an abbreviated program. You can establish a new pseudo disc by having these functional tasks, and the pseudo disc is now going to replace what was your disc that was displaced, particularly anteriorly displaced. And that's a lot of what will stop the clicking or the popping that happens in the jaw. Okay, so really important TMJ that you're able to do a program. OSA, I thought this picture of the baby was just so cute. I don't think that this baby has obstructive sleep apnea. And I'm not saying to work with babies that have obstructive sleep apnea. I just thought it was a cute picture of a baby with its mouth open. And so that's why it's here. Okay. Just so that I don't get any comments later on about that. But obstructive sleep apnea, there's a lot you can do. Just look at the Snore Gym app. Just look at all of the research around oropharyngeal exercises. Like, you do not need a full myofunctional therapy program to be impactful. You really just need to be aware of corticomotor function in the oropharyngeal space and what all that means. So I was on a call. I don't even know if it was a call per se, but I was on a webinar of sorts with a particular person who's public, like facing, very popular, but like in the world of Myo, I don't think anybody even really knows who this person is. And they were trying to educate about all these different exercises that they do, these 5 exercises that they do and that they recommend for everybody who has obstructive sleep apnea, like everybody. And absolutely none of them targeted posterior tongue musculature or the velopharyngeal space. And like none of that velopharyngeal corticomotor function was addressed in any way, shape, or form. And so it's really important that, one, you know what you're talking about. Like, don't issue exercises if you have no idea what they do. Like, at least read a paper, and one of those papers that have 7 to 10 exercises, and like pick 5 from that if that's what you want to do. But you have to understand that it's all about the airway for obstructive sleep apnea. It's got nothing to do with like the tip of the tongue and like lateralization. Like these things have nothing to do with obstructive sleep apnea. So when you're dealing with obstructive sleep apnea for an abbreviated program, you're really looking to strengthen and engage that pharyngeal wall and the soft palate. So you're looking to establish like what a night lace would do, right? Or Sonoma sleep, or all these things. They have their own things. Light Scalpel has one too. It's like the night lace, where they're really working to establish collagen in the space using the laser. And that collagen is going to tighten up that soft palate, and then the uvula is going to sit up higher, and it just opens up the airway a bit more. But you could do that naturally by strengthening and engaging the soft palate musculature. And so as long as you're working and targeting on that, you're going to start seeing results for your obstructive sleep apnea patients. But you also want to introduce nasal hygiene, sleep hygiene. All these things are really important for them in their day-to-day life and tasks. That way they're able to facilitate patent nostrils. They're able to facilitate better sleep. If they have posturally induced obstructive sleep apnea, being able to sleep in a different position or getting some sleep hygiene that will enable them to satisfactorily sleep in a better position is going to be key. Establishing posterior tongue engagement and lingual palatal suction and seal gets the tongue up and out of the airway. Like, these are the tasks that we want to work on. If we're working on tongue stuff, it's got to be getting the tongue up and out of the airway. If we're not working on that, I don't know why you're doing an exercise for the tongue, but that needs to be your focus with obstructive sleep apnea. And so make sure that you're always just pushing forward in the right way. Breathing is a big thing. Have you ever met a mouth breather that didn't have what you expected to see in oral myofunctional disorders? Let me know in the chat. Like, give me a yes or no. A lot of times, the key sign that you need myofunctional therapy is that your mouth is wide open, or even not wide open, but your lips are apart. And when it's apart at rest, your tongue is low. Like, we know you're not in proper oral resting posture. And so you expect a wonderful sequence of events to follow. But then you're surprised to find out that, maybe they don't have all these issues. Maybe they just have some, and it's not like complete and utter chaos there like you expected. It's absolutely normal to meet a mouth breather that does not need all of the things, okay, like a full myofunctional therapy program. Sometimes their mouth is just open. Sometimes it is just a gap, but they're actually breathing through their nose. So there's, pardon me, there's other things that you can work on with them, and you could really just work on breath work and breathing exercises as its own limited program. And that'll also help you in turn with vagal tone. I have another lecture that I did that you can look in like the archives of this YouTube channel or the LinkedIn for where I talk about breathing, myo and breath work specifically. And we dove deep, and there's even some breathing exercises at the end for you and like how it all works and comes together. But essentially, you can increase your oxygen levels through deeper breathing because you're going to fill those sacs. The deep breaths are going to increase the oxygen pressure in the lung sacs. And so you're going to fill the sacs just a little bit deeper by altering that breath and making it easier for blood to now absorb or work with or carry the oxygen so that you can have oxygen flow to all of the wonderful organs that need it. Okay. It's also going to turn on your parasympathetic system. I'm sorry. I don't know why I need to clear my throat. I'm just going to take a quick sip. Okay, you're also turning on your parasympathetic system, which is going to increase your relaxation and some of your alertness. Like, you're just a little bit more alert. You don't get glazed and focused over like when you're in freeze state, when you're in your sympathetic state. It's going to improve your attention and emotional state, improve your sleep cycles, and reduce stress. So breathing and having a program of breath work that you do. There are people who just follow Buteyko and might do only Buteyko and no Myo for somebody. You can do that. Breath work, I want everybody to remember, is an overarching term for dozens. There are dozens of breathwork modalities, and there's so many different ways that they can impact a person in their body, and there's no one way to do it. And so just know that breathing is dynamic, and you want to be as dynamic as the people who are coming to you. They are coming to you with their own unique set of problems, and you can do a whole breathwork or breathing abbreviated program. But when in doubt, step it out. This is an older, it's not that old because, I was teaching with Team Myo not that long ago, but this is an old graphic that I had created with our orders of operations or the staging that you would do in the program. And I still teach to this because I still like utilize this. I just don't use this particular graphic. It's a dental sleep toolbox graphic that company is gone. And so here we go. Here's a wonderful special tool for all of you guys who stuck around till the end here. Habit elimination is like the foundation. Like habit elimination has to be done prior to starting, but then you can really get on the steps, right? So we're working on lingual skills and then palatal seal, lip strength, suctioning, swallowing, chewing. Suctioning is in like buccal suction, anterior suction, like suctioning, collecting of liquids, not necessarily palatal suction because that's palatal seal. But we're working on these in this particular order. If you wanted to do an abbreviated program and it wasn't necessarily like one of the things that I talked about before, well, look at what you don't need to work on, like probably that last step there, because remember, we can't do an abbreviated program if they need that phase of habituation and like phase 3, they can't do that. But look at what you can work on based on the lower tiers of steps. Like if they can establish palatal seal, you don't need that, right? If they got good lingual skills and palatal seal, maybe it's just a abbreviated program with just lip strength and just working on lip strength and awareness. Maybe it's a breathing or nasal hygiene thing, which really goes along all of the steps. And so it's from the beginning all the way through the end. You can work on breathing and nasal hygiene. But think about what you can probably do. Like, when in doubt, step it out. Take the steps of how you would actually approach a program, how you would actually sequence your program, how you would work with somebody individually. And once you're doing that, you'll be like, oh, I can take this out because they don't need it. And I can focus on this because this is where their true needs are. And you'll be able to really develop your own program. Okay. If you want like more details about how you can really work that out, like that's actually in a course. And so that's, neither here nor there. But I figured the graphic was just a really good way to get that visual of like, if I'm just thinking about what's my next step, then I understand that, it's this and this and this and this. And you'll really put together how everything should fall in line. Okay. You can be there to help. There's going to be people who need your help, who like desperately need your help, but you could be there to help people who don't need a full program, but do need to prepare for oral surgery and need to recover functionally from that, who need just some nasal hygiene, who need to eliminate an oral habit like thumb sucking or nail biting. They need to establish a sleep hygiene or develop just better skills in some area, whether it's labial skills and really like working on the lips and lip strength because they're breathing through their nose already. And maybe we just have to get the tongue up and the lips closed and we're good there. Who knows? You could just really enhance their awareness of such. You can be there to help. It's the little things that really make the biggest difference. And so an abbreviated program is a great way for you to really develop the best out of some of the people that you work with. And so I want to end on, and feel free to put any questions in the chat, and I'll go to that in just a minute. But I want to end on a really light and nice note. If you do enough small things right, big things can happen. I think that is really impactful. Okay. So we're going to end there. If you have any questions, throw them in the chat. Let me go look at the chat really quick. Hey, ooh, I love this. We are going to put that up there. Sandy would like to hear more about trauma because it definitely affects a lot of people. So we'll put that on our to-do list. So we'll definitely get a trauma lecture in probably in 2 weeks. I'm looking forward to seeing you guys next week. Next week, we're going to talk about just all the misconceptions or some of the misconceptions about myofunctional therapy that newer therapists feel, like wanting to feel like you can fix all of the things and just understanding that no, you probably can't fix all of the things. So we're going to get into some of that next week. But between now and then, it was such a pleasure. Ooh, I just got a question. Hold on, let me put that up there. How to determine a fee for abbreviated Myo. Determining fees for abbreviated Myo is really going to be based on, okay, so if you have a program fee and you divide that program fee by however many sessions you would actually do, then just think about what's your abbreviated fee. Like, is it half? Are you planning on working with them? So let's say you have 14 sessions that you plan on working for a full program, but you think that you can work with this person for about 7, then maybe that's half of your program fee. Or if you could work with them and it is going to be maybe 4 sessions, and it's really going to focus on education and sleep hygiene and nasal hygiene and really just lifestyle choices, then what's your per session rate? And then I would multiply that by 4 if you want to make it a mini program, and then that's what it would be for me. That's what I would figure. Um, Great question to add on. How long should the program be, right? The longest that you think that you need to work with them. I mean, I really don't go by a certain timeline. Even with tongue tie, it's 3 to 4 maybe before, 3 to 4 maybe afterwards. I'm really preparing you. So when you're prepared, I'm preparing you for release, and then I'm following healing throughout. Not everybody's done with healing like textbook style when it says that they should be done with healing. Some people are still in need of a little bit more. So I'd give a range. And then I think from there, from having a range and understanding what that range would be, Cindy, that will be the best way for you to kind of sell that treatment. So I think that you don't need a full myofunctional therapy program, but we can possibly work together for somewhere between 4 to 6 sessions, and we'll kind of look at that as we're going along. I think that's a great way to phrase that. Just me. All right, guys, it has been an absolute pleasure. As always, if anybody is ever interested in, chatting, you can always chat with me at any point in time. Um, I have a meeting link. Let me put that in the chat. And it is always available for whoever wants to chat with me. It's bit.ly, chat with Carice. There we go. And then from there, we'll be able to chat. Okay. It's been a pleasure, guys. I hope everybody has a really great day. Bye, friends.